So a lot of our patients that come to us seeking a flat closure were never really offered other techniques for reconstruction other than an implant-based reconstruction. So for some of those patients, not all of them, we talk about a DIEP flat breast reconstruction or some other type of autologous tissue reconstruction and offer that as an option. I think it's important that patients know what their options are, particularly in the context of trying to go flat, that there are some patients who are still good candidates for autologous reconstruction, but many people choose to just be flat, and that's good. That's the right answer for them.
I think it's always important, and we do this in every one of our consultations when we can actually meet the patient before their mastectomy, certainly, to remind people that it's an option, just like a reconstruction, to not have a reconstruction. And so no reconstruction, a flat closure option is certainly just as viable as a reconstructive option.
I think what's more important is understanding the patient's goals, what their life is like, and fitting the right approach to meet their needs. The right answer is what works for that patient. And that means understanding what's important to that patient and offering the right solutions for their problems.
And I think it's equally important to emphasize that just because at that moment in time, maybe that decision was the best one, not having a reconstruction doesn't mean it's a forever thing. It's very easy to change one's mind and come back later, and there are plenty of reconstructive options still on the table in that setting.
Yeah. All right, so we work hard to try to deliver a flat closure to patients who've undergone breast cancer surgery, who've undergone a mastectomy, have elected not to have a reconstruction. That means no implants, no autologous tissue like a deep flap reconstruction, and really opt for a flat closure. But a flat closure, it really varies. A flat closure for a patient that's 5'7", 115 pounds is very different than a flat closure for a woman who's, let's say, 5'2" and 180 pounds. Their anatomy is different, the amount of excess tissue they have is different, their breast volume before they had a mastectomy is different, and all those variables have to be accounted for when you're trying to get a nice, even, flat, cosmetically acceptable closure. And in some ways, a flat closure is a bit of a reconstruction.
It really is. I mean, a lot of the work we have to do to get the tissue to stay flat is not just cutting and sewing. It's at the time of mastectomy, all that tissue is going to have to stick back down to the chest wall because it's been elevated, and it now needs to kind of rest in a new place, in a new location. It's very hard to predict where that's going to happen. So one might actually try really hard even to do a flat closure at the time of mastectomy, and it probably, or actually may not, pan out that way. And so it does take a lot of work afterwards to be able to come back after the tissue swelling has gone down, after it has settled into its new location and places, and to be able to deal with those changes and using plastic surgery principles like the things we do.
Yeah, we see a lot of patients about 3, 4, 5 months after their mastectomy. Now the tissue is softened up, the swelling's gone away, and then we can use plastic surgery techniques like tissue rearrangement, perhaps fat grafting, perhaps cutting out standing cone deformities to make the closure flat, even, symmetric, without any areas of concavity type deformity. But all those things, in our experience at least, takes a separate procedure where we're really focused on the principles of flat closure. And that's oftentimes about 3 to 6 months after mastectomy.